So, what the book really says is that the widespread use of these medications in our society and increasing diagnosis of people and keeping people on drugs long term with this whole story that they fixed the chemical imbalance, it's been a public health disaster.
Welcome to Mind, Body, Health, and Politics. I'm your host, Dr. Richard Lewis Miller. The mission of Mind, Body, Health, and Politics is to enhance your physical and emotional well-being and encourage community. I say encourage community because I believe that human beings are basically tribal animals and that we do the best from a health perspective, emotionally and physically, when we live in small tribes. This is a time in America when it's important that people consider tribal living again because of the tremendous socioeconomic stratification that's going on that has left 70% of our country living paycheck to paycheck. So from an economic point of view, it makes sense to live tribally. Furthermore, we have more people graduating from college and moving back in with their folks than at any time in history. Marriages are being postponed. People are getting married later and having children later, all for economic reasons. So consider some aspect of grouping together in order to sustain. Today, we have our old friend, Robert Whitaker, back with us. Some of you may remember that when his book came out about 10 years ago, Anatomy of an Epidemic, we had him on this program, and I invited him back today for a catch-up on what's new. Welcome to Mind, Body, Health, and Politics, Robert.
Thanks for having me. It's a pleasure to be here. Looking forward to it.
So, your book, Anatomy of an Epidemic, informed us about the SSRIs. Give us a quick summary of that book, and then we'll move on, because I want our listeners to have a little catch-up, a little foundation for the magnitude of the piece of work that you brought us.
Yeah, that book really looked at a question that is important to people in the United States and around the world, and that is, how do psychiatric drugs affect the long-term course of major mental disorders? Now, the understanding or the expectation is they're going to improve upon the long-term course. And when we say long-term course, disorders have a spectrum of natural outcomes in the absence of medication. So you want to see does using antidepressant medications, for example, does that lead to a better long-term outcome than not using antidepressants at that first moment of being depressed? And then, especially if you stay on the antidepressants long-term, what is the difference in outcomes? So I did this for antidepressants. I did it for, believe it or not, antipsychotics. I did it for stimulants given for ADHD. And I also looked at changing outcomes for bipolar disorder. And the reason this is, I think, such an important subject is the way we test drugs and they get approved for market is we say psychiatric drugs. In clinical trials, do they show that they knock down the symptoms of a disorder better than placebo? Yes. And if you have a small benefit, you say that drug is safe and effective, and hopefully the risks aren't too great. And then it's put on the market. But that's for 6 weeks. What happens to people when they take antidepressants for 1 year, 2 years, 5 years, 10 years? And what you find in this book, and when I say in this book, it's in the research literature. I didn't come up with this information. I just scoured the research literature to try to answer that question. And what you find is in every major disorder category, long-term use of these drugs, it increases the likelihood that you'll remain symptomatic. And that means not everybody happens, but that's against this contrast to what happens naturally. It increases the likelihood you'll become functionally impaired and actually go on disability. And of course, there are additional side effects, physical adverse effects that come with long-term use of the drugs as well. And you see this for every major class of drugs. Now, the antidepressants, oddly enough, the SSRIs are particularly problematic because they also bring with the problem, all the drugs have this, but SRIs seem particularly notable, of getting off the drugs is very difficult. People, once they're on them for a long time, they may experience really difficult withdrawal symptoms and what we call protracted withdrawal symptoms. So what the book really says is that the widespread use of these medications in our society and increasing diagnosis of people and keeping people on drugs long-term with this whole story that they fixed a chemical imbalance, it's been a public health disaster. And the importance of this book, I think, was that information is contained in the research literature published in major psychiatric journals. And I really think I was the first one really to put it together into a coherent, evidence-based story about how psychiatric drugs affect outcomes over the long term. And that was published in 2010. I did an update in 2015. And real briefly, I will say since then, there is abundant new evidence that confirms that view of the psychiatric drugs.
Robert, I think I've told you this in an email, and I'm going to say it out loud for the public to hear. I've been broadcasting Mind, Body, Health, and Politics for 20 years. Your interview had one of the most profound effects on me and my clinical practice of any interview that I have done. It was really stunning to hear what you're now once again sharing, that not only are these medicines not helping, but they're actually making people worse. Now, and that's the evidence that you researched, as you said, and I appreciate your saying it that way. You're not a scientist, you're a journalist. You went out, you did the research, and brought it together for us in one place, Anatomy of an Epidemic. Glad to hear you republished in 2015. Now, did anyone else listen to you except Dr. Richard Lewis Miller? Did it have an effect on clinical practice around the country? Have people been in touch with you about this? Have the media picked up on the importance of your work?
Boy, there are many dimensions to that question. It has had a nice impact in many different ways. I can't tell you how many people I've heard from, individuals who are saying that putting this information together gave them a new narrative to understand their own lives. And this is particularly true of people who had been on the drugs for some period of time and had worsened on them. And of course, they were always told, oh, that's just your disease. It's your treatment resistance. And they saw in Anatomy of an Epidemic a different narrative, and many people got off the medications and did quite well, and they feel they got their lives back. So that's an impact on an individual level. Now, it has had an impact on the discourse within even the sort of scientific world of psychiatry, in the evidence-based, what people who like to say, what is the evidence base for psychiatry? So you'll see, for example, and this was seen as heresy 15 years ago, there is now an open admission within the top echelons of American Western psychiatry that there's no evidence actually that antipsychotics improve long-term outcomes. Now, that would have been seen as heresy. Now, they don't want to say that they worsen outcomes, but they have shifted from, we know these drugs are good for people long-term, to, well, actually, we don't know that. That evidence isn't there. Antidepressants now, there's increasing, and there's been, by the way, this is part of what I want to talk about. One of the things the book did do was stir more research into the long-term outcomes. And you see new studies on schizophrenia outcomes for people with milder psychotic disorders, depression, et cetera. So there's actually a much more robust literature on long-term outcomes today than there was 15 years ago. And I do think Anatomy of an Epidemic, in fact, I know, helps propel interest in this question. So that's happened. So we see a more robust database on this very question. And by the way, I don't know of a single study, other than when they do these drug withdrawal studies, what they call relapse studies, where they take people who've been on the drugs for a long time, and they take one group and keep them on the drug. The other drugs, they abruptly withdraw them, say with antipsychotics. And it is true that the group that is abruptly withdrawn relapses at a higher rate. But that's a study being done in what is the risk if you've been on these drugs and you come off abruptly. There's that sort of evidence. Beyond that evidence base, there is an increased admission within the sort of the really people who know this research well, that there just isn't evidence for any of these drugs improving long-term outcomes. And I will say this, there's an increasing body of evidence that, for example, recovery rates are higher for psychotic patients who get off antipsychotic medications long term. That comes from many different countries. The antidepressant story just keeps getting worse and worse. So there was a paper published in 2012, sort of picking up on what I had written about, saying, do these drugs cause a tardive dysphoria? In other words, do they induce a chronic depression? And then there's been a lot of people step forward with saying that's what the evidence seems to say. Now we call it treatment-resistant depression, but treatment-resistant depression before the SSRI was rare. The understanding was even if you didn't take antidepressants, you had a very good chance of being well in 6 months, 9 months, that sort of thing. So we've had an impact on the scientific literature. There's no question about what's being studied. And public, as all this is happening, more information. Many anatomy is sold well. I also have a website where we update the scientific literature all the time called Mad in America.
Say it again, please.
I have a website called madinamerica.com where we provide access to all these studies. So there you can do your own research. And we also have daily science reports, keeping up on new reports that help us understand the effect of medications and all. So you have that impact. You have more and more societal discussion saying this paradigm of care, the disease model, hasn't worked. The disease model being born in 1980 when the American Psychiatric Association published the third edition of its Diagnostic and Statistical Manual. And there's this growing voice saying whatever we're doing isn't working. Now, if you're within the psychiatric sort of guild, you're blaming it on the system. You're not blaming it on its drugs. But nevertheless, there is a growing sense that this disease model hasn't panned out. And by the way, there's been calls for a paradigm shift in thinking from the World Health Organization and from the United Nations. And those people read Anatomy of an Epidemic. We've covered their work, and they even hired some of our people to be consultants on their reports. That's an example of how this sort of approach to the science of psychiatric drugs is spreading. However, and this is the big however, use of psychiatric drugs just keeps going up and up and up. And the diagnosis of people keeps going up and up and up. And you see it in particular with younger people going to college. There's stories now that more than half of college students will access mental health services during their 4 years. Somewhere between 25 and 30% arrive at college with a diagnosis and a prescription. So even though we have this abundant evidence gathered over the past 45 years, evidence of many different types, by the way, public health outcomes, studies that compare medicated versus unmedicated people, looking at how the drugs may be affecting brain chemistry in a negative way, that sort of thing. Even though we have all of that, which tells of a paradigm of care that does harm at a public health level and to many individual lives, it hasn't thwarted the actual clinical use of these drugs. It just keeps going up and up and up.
Robert, in your book, you talk about the medical chemical imbalance theory, and you describe how the scientists and the companies were taking a position that people that were suffering from various kinds of emotional problems, whether we call them psychotic, neurotic, whatever, but they're suffering mentally and emotionally. The theory is that they were suffering a chemical imbalance. And as I recall, what you said in your book is that science tells us this is not the case. So what happens when you take these medications to supposedly correct an imbalance, you're creating an imbalance. And therefore, the people all the time they're on these medications are living with this imbalance created by the medication. And then what puts the salt in the wound, as I recall, and correct me if I'm mistaken, is that when people attempt to come off these medications, they go through various kinds of symptoms and feeling abraded, uprooted, and really bad. And the doctors tell them, oh, that's your symptoms returning. Whereas in fact, what you're saying science is telling us, No, that isn't your symptoms returning. That's either withdrawal from the medication or that's you returning to a balanced state from this very imbalanced state. Did I get that right?
Yeah, this is really at the heart of the incredible betrayal of first the US population, but really a global population. Because, if you look at it, the chemical imbalance story, if you believe in it, is a story of great medical progress. It's a story of researchers discovering the very molecule that causes madness, the very molecule that causes depression, the very molecule that causes kids to fidget in school and get diagnosed with ADHD, and they can fix it. They have a drug that can fix that, like insulin for diabetes. Now, if that were true, and that's what we were all told, and we organized our thinking around as a society and as individuals, that would be the greatest advance in medical history, given the complexity of the human brain. However, as I wrote in the book 2000 in Anatomy of an Epidemic, is if you trace that whole story, where it arose from, you find that it was a hypothesis born not of an understanding of what was happening in people, but an understanding of how the drugs affected a neurotransmitter transmission in the brain. So, for example, antidepressants were found to block the normal reuptake of serotonin from that synaptic cleft, that gap between neurons in the brain. So it blocked that normal serotonergic reuptake from that gap. And because of that, the serotonin was staying longer in that gap. And so theoretically upping serotonergic levels. So people hypothesized maybe depression is due to too little serotonin. And the other big thing was around antipsychotics. Antipsychotics block dopamine receptors in the brain. They thwart the normal transmission. So researchers hypothesized maybe schizophrenia and psychotic disorders are due to too much dopamine. So first thing you have to understand is it arose as a hypothesis, okay, based not on what they were finding in the brains of people so diagnosed, but rather from an understanding of how the drugs acted on the brain and then hypothesizing, though, maybe the opposite is the abnormality that causes it. So now once they make this hypothesis, which goes back to the 1960s, they have to say, do people with depression have too little serotonergic activity before they go on the drugs? Now, as early as 1980, the NIMH tested that possibility and said, we're not finding anything wrong, abnormal, any lesions in the serotonergic system. That's 1984. So go forward with that. They do all sorts of efforts to see, do people with depression, before they go on the antidepressants, do they have an abnormal serotonergic system? They didn't find it to be so. And here is what's so important. In 1998, the American Psychiatric Association's own textbook declared that low serotonin theory dead. They said, we've investigated it. We haven't found it to be so. And it's sort of a stupid hypothesis anyway, or a simpler one, a very simple-minded one, because there's no reason the pathology of a disorder should be the opposite of whatever is affecting the symptoms, okay? We weren't told that, but that's in their textbook, okay? Now, the story about finding whether schizophrenia was due to too much dopamine activity is a little bit more complex, but as early as 1992, someone named John Kane, a famous schizophrenia researcher, said the simple dopamine hyperactivity story of schizophrenia is no longer credible. 2003, you had Stephen Hyman, a former director of the NIMH, saying there's no evidence that there's a lesion in the dopamine system. So, it arose from not investigations into people, but rather drug action. Then they looked to see, did people have these problems before they went on the drug? They didn't find it to be so. But now you're getting to your third part. You go on the drug, and now your system does, in order to compensate for the presence of that drug, goes into an abnormal state. So let's go, for example, on an antidepressant. Antidepressants act as an accelerator on serotonergic activity, right? They block the normal reuptake of serotonin from that synaptic cleft. Well, your brain, trying to maintain what is called a homeostatic equilibrium, its normal functioning, says, the drug is upping my activity. I'm going to have to dial down my own serotonergic machinery. So maybe I'm going to reduce the density of my receptors for that chemical messenger, or maybe my neurons are going to put out less of that chemical. So When you got depressed the first time, before you went on a drug, did you have a serotonergic abnormality? No. But then the drug perturbs the normal functioning of your serotonergic system. And after you go on it, it drives your brain into the very abnormal state, low serotonergic activity physiologically, hypothesized to cause depression in the first place. That's what the science shows. And it shows it, by the way, with antipsychotics too. So with antipsychotics, they block dopamine receptors in the brain, right? So they hypothesize maybe people with schizophrenia have too much dopamine activity. Now, the irony of this story is when they first did such studies and figured out how to measure the density of dopamine receptors in the living brain, they said, we have found the cause of schizophrenia. They have too many dopamine receptors. The New York Times reports the cause of schizophrenia has been found. But then if you read the paper, they said, we don't know if this is due to the disease or caused by the drug. And then very quickly they found, in fact, that it was a reaction to the drug, and you can understand why. The drug acts as a brake on dopamine activity. Your brain, trying to maintain a homeostatic, its normal functioning, puts down the accelerator on dopamine activity. And one way it does that, it increases the density of receptors for dopamine. And as researchers wrote as early in the 1980s, they said the brain is now super sensitive to dopamine, and it looks like it's making people more biologically vulnerable to psychosis than they would be in the normal course of the illness. And you also see it with the antidepressants. So there's a paper that talks about tardive dysphoria, and it talks about how antidepressants induce this change in the serotonergic system, driving it into a low state that A, may lead to a chronic tardive dysphoria, and B, if you try to get off, it's going to be very difficult. And here's the reason, think about this. You're on an antidepressant. It acts as an accelerator of serotonergic activity. Your brain puts down the brake, okay? Now you take away the drug, and what do you have? You still have this abnormal state. You have the brake on your serotonergic system. Now, just not to alarm your listeners, that was the simple understanding of why you had withdrawal symptoms before. Oh, and by the way, can I add one thing, Richard? In 1995, the director of the National Institute of Mental Health at that time, Stephen Hyman, who was also a neuroscientist, he wrote a paper called A Paradigm for Understanding Psychotropic Drug Action. Okay, this is our top guy at the NIMH, and he says, these drugs work by perturbing normal neurotransmitter function in the brain. And in response to that perturbation, the brain undergoes a series of compensatory adaptations, trying to maintain a homeostatic equilibrium. And at the end of this compensatory process, the brain is now operating in a manner that is both qualitatively and quantitatively different than normal. So the public around the world was being told that these things are caused by chemical imbalances, and we have the drugs that fix that chemical imbalance. Science was telling us the causes of these disorders biologically are unknown. There's no evidence that serotonin is abnormal or even that dopamine is overactive in schizophrenic patients. So, what science said is, and now we have drugs that perturb normal functioning and induce the very abnormality hypothesized to cause the problem in the long term. And finally, researchers are saying that's one reason for the rise in treatment-resistant depression, okay, and this sort of chronic dysphoria state. And we can talk about what we saw in the largest antidepressant trial ever conducted, because the long-term outcomes were something like you've never seen before in terms of how poor they were. But also, beginning in 1980, in early 1980s, there was researchers saying this compensatory process with antipsychotics is making people more biologically vulnerable to psychosis. And it's also a problem because once they are on the drugs for a long time, it's very difficult to come off, and they're serving as a trap. So, and by the way, in the best long-term study we have of schizophrenia outcomes in the United States was done by Martin Harrow and Thomas Jobe. Now, I wrote about him in 2010, but they continued to do some research and update their findings. But they were from Illinois. One was a psychiatrist, one was a psychologist. And in their long-term study funded by the NIMH, schizophrenia patients who got off medication had an 8-fold higher recovery rate at the end of 15 years than those who stayed on their drugs. They were also much less likely to be actively psychotic. And so what did they say in their papers?
Repeat that whole sentence again.
Okay. So in this best NIMH funded of long-term outcomes for schizophrenia patients,
Yes.
and also patients, they had two different groups. They had patients with milder psychotic disorders, but focus on the schizophrenia.
Yes.
The patients who got off their medications, particularly by year 2, they just stopped taking them. They just stopped them. They had a long-term recovery rate of 40%. Okay, 40% ended up asymptomatic, functioning pretty well. 80%
Off the medication.
off the medication. What was
Right.
it? What was it for the group that stayed on the medication, that were medication compliant?
Yes.
Only 5% recovered. Virtually no one worked, and they were much more likely to be actively psychotic and anxious years down the road. They were much more chronically ill. So that's our best long-term study we have. And what did they conclude? That antipsychotics worsen the global outcomes of people diagnosed with schizophrenia. And when they did papers trying to understand what might be going on biologically, they pointed to this drug-induced dopamine supersensitivity. Now, that's in the research literature. There's numerous papers on it. Mad in America, my website, covers it a lot. We've really promoted it. You don't read about it in our media. You asked about the media. The media just won't touch all this information that undercuts the conventional narrative that American Psychiatry as a guild have told us. So this information, which you can find, you can go to the studies, you find a lot of it on Mad in America. You just don't find it in the major media, and that's an extraordinary failure on the part of the major media. And we can also talk about what happened in the largest antidepressant trial ever conducted, because that's quite a story too.
Before we talk about that study, which I'd like you to talk about, I'm going to take a slight sidebar and talk about the little box, the synapse, and what it is, right? So if you're listening or reading this, picture a junction box in the wall of your house, and electricity comes in one side, and electricity goes out maybe 3 or 4 other places. And the way it's done in the house is the wires connect to something so that the electricity in gets dispersed mechanically to those wires that are going out. What goes on in the brain is the junction box is called the synapse, and information goes in one side, and then it has to make it to what's called receptors that Robert has been talking about. And there can be many receptors sending information to many different places. The way the information gets from the send-in side to the receiver side is through chemicals rather than a direct mechanical connection. And these chemicals are called neurotransmitters. They transmit the information. They transmit it through chemical process. And these swimmers that swim across the junction box called the synapse, one of them is called serotonin, another is called dopamine, and we have many others. But serotonin and dopamine are the ones that have been so far identified as having so much effect on the emotional system. So the SSRIs and the antipsychotic drugs have an effect on the receptors. Remember, they're called selective serotonin reuptake inhibitors. They inhibit the little receptor boxes from reuptaking the swimming serotonin or dopamine so that it does not get distributed throughout the body, throughout the brain. Did I get it right, Robert?
All except the last little part's a little different with the SSRIs. So it was all perfect. It was all perfect, but it's not that. So, let's just talk real quickly about serotonin. You have a presynaptic neuron that releases that molecule, serotonin, the tiny gap, and it binds with receptors on the postsynaptic neuron, the receiving one. Now, think of a messaging system. It has to be crisp. So you get a burst of serotonin, and now that has to be removed from the synaptic cleft, okay? And the way it's removed from the synaptic cleft is one of two ways. It's either taken back up into the presynaptic neuron and stored for reuse, or an enzyme comes along and metabolizes it and is carted off as waste. So what an SSRI does, it blocks that normal reuptake, that removal of serotonin from that gap. It stays in that gap longer. And so because it's theoretically in the gap longer, it's now binding with receptors on the postsynaptic receptors more, so upping serotonergic activity. So it's not just that it diffuses it. The idea is it keeps that molecule in that tiny space longer than normal, and that ups serotonergic activity. And with and then we just so to finish your your very good explanation of this, what do antipsychotics do? Antipsychotics so receptors are a protein that there's a key and lock idea. Acts like a receptor. The neurotransmitter is like a key that fits into the lock, the receptor on the postsynaptic neuron. So when that normally happens, that's part of how you activate that second neuron. But what antipsychotics do is they sit in that receptor, but now the dopamine can't get in there, so it blocks this normal transmission. It's like pouring glue into a lock, and you can no longer operate that receptor. So that's why it thwarts dopamine transmission, because you're in essence pouring glue into all these receptors for dopamine, and you're blocking that transmission of dopamine function. But now, going back to our story, what does the brain say? My dopamine transmission is not working well. I better create some more receptors. And all of a sudden now you have maybe 50% or 100% more receptors than normal. So it's just a tiny little bit of like what happens to the molecules and how they're perturbed with psychiatric drugs.
Okay. Now let's move on to the big study.
Okay. It's just, Richard, it is complicated to explain that whole story of how neurotransmitters work and all. And the other thing about this whole thing about
I think we covered it. I think we got a pretty good, people can have a visual image. Yeah.
Okay, great. And think about how many synaptic gaps there are in the brain. Isn't there something like 100 million synapses in the brain or something like that? It's just the complexity of the human brain is unbelievable. Okay, now we'll go on to this other study. The biggest study ever conducted on antidepressants is called the STAR-D study. It was funded by the NIMH. It goes back to around the year 2000. And when they mounted this study, they said, this is the study that's going to tell us how to treat depression. And the reason they said this. Clinical trials are done in a select group of patients that don't represent real-world patients. So, for example, when drug companies test their antidepressants trying to get them approved by the FDA, they'll test them in people with that aren't comorbid for other diagnoses or don't have suicidal feelings. And researchers have said anywhere from 70 to 80% of real world patients can't qualify for an industry funded clinical trial. So the NIMH, when it funded the STAR-D study, said, this is going to tell us how effective these drugs are in real world patients. And with antidepressants, can we keep people well? Can we get them well? That's one. And then can we keep them well? And they said, this is such an important study. We'll make sure all the country knows it. We'll disseminate this information, and this will guide our protocols for going forward. Okay. Now they entered 4,041 real-world patients into the study who had really only moderate depression. They were outpatients. They weren't in-hospital patients. They had a score of 14 or more on the HAM-D score, which is a tool used to measure the severity of depressive symptoms, and 14 is moderate. And the way the study was designed was this. You got first an antidepressant to see if you could remit on that, go down below 7. And if you did remit in that first stage, then they would put you in a follow-up trial and see if you could stay well for another year. Now, if you didn't remit in the first one, you got a second try to remit of 3 months. Each of these stages was 3 months. And with the second try, you would be like a different antidepressant or a combination of antidepressants or maybe antidepressants and psychotherapy. If you didn't do it on the second time, you got a third chance. If you didn't do a third chance, you get a fourth chance. And part of the idea was this, was if you didn't respond to a certain antidepressant, you would respond to a different one. Now, the news that was announced in 2006 was good, was boy, they work. What they said is at the end of four stages of treatment in that acute period of time, 70% were cured. Their remission, went into remission, their depression went away. So the message went out, if the first drug doesn't work, just keep trying. Try a second, try a third, and try a fourth. We'll learn that, you'll finally find one that works for 70% of people and their depression will go away. Now, that protocol became the protocol for how they used antidepressants in the United States and really around the Western world. Now,
Yes.
the truth of the matter is that's not what happened in the study. What happened in the study, and this actually became, I could tell even in 2010 when I was writing Anatomy of an Epidemic that something's not right with this study. But researchers, a psychologist named Ed Piggott and a couple of other researchers have used freedom of information requests and that allowed them to get the study protocol and also the patient level data. And a year ago, they published a reanalysis of what happened to those 4,041 patients. And they said if the protocol had been followed, the true remission rate at the end of one of those four stages was 35%, not 70%. Now, how did they artificially inflate from 35 to 70%? One, you're not going to believe this, they counted people who were not depressed enough even to enter the study. In other words, they either lacked a baseline measurement or it was less than 14. So they weren't even eligible for the study, but nevertheless, if they somehow at a later time they were allowed to continue to go below 7, they were counted as remitted. That's number one. Two, they switched endpoints. They were supposed to do a thing where they were going to measure by remission by HAM-D scores, and they were going to use another measurement that wasn't validated called a QID score just to look at how they were doing at every clinic visit. And what they found is that with the QIDs, which hadn't been validated, many more people scored in remission, so they just began reporting remission rates based on QIDs, even though the protocol said QIDs will not be used to report research results. That's the second. Third, they had a deal that if you didn't come back after your first treatments and dropped out, that would be seen as a treatment failure. What they did instead is they just dismissed those from the people said to enter the trial. And then fourth, with other dropouts, they said just if these people had stayed in the trial, even though the protocol said dropouts are failures, they would have remitted at the same rate of people who stayed in all through four stages. That added another 900 remitted cases. That's how this is research fraud, by the way. It's research fraud to do this. That's how they doubled the remission rate. Now, that's only half the fraud. So they came out with this, by the way, last summer in the British Medical Journal. And basically, the authors didn't deny it, but that's what they had done. It is fraud. Now, the second part is even in some ways of equal or even greater interest to the public. So remember, if someone remitted at one of those stages, then they were whisked into a follow-up trial. And in that follow-up trial, they would get ordinary good, close attention clinical care, okay? But the doctors could change their dosages, they move to other drugs, whatever they wanted to do in the clinic to try to help that person stay well, okay? And the thought was, we're going to show that if you stay in care, you could get well and stay well. That was the point. Well, in that final result, they never really mentioned the one-year results. There was this graphic that you couldn't make sense of, but they never discussed it, okay? They clearly were hiding the one-year result. Well, this team of researchers put it together, and here is the bottom line result from the largest antidepressant trial ever conducted. At the end of 1 year, if you look at the 4,041 patients who entered the trial, only 108, 3%, had remitted and stayed well and in the trial to its 1 year in. So the documented stay well rate in the largest antidepressant trial ever conducted was 3%. Now, this part is interesting too. The NIMH at the same time basically was saying, well, what is the natural recovery rate at the end of 1 year for people off medication diagnosed with depression? You know what they found it was? NIMH study, 1 year stay well rate. And how many people have gotten well and stayed well at the end of 1 year? So in the NIMH studies, the stay well rate at 1 year was 85% for those off medication. And in this other STAR-D study, they could only document that of people who entered the trial, that 97% either never remitted, um, dropped out, or remitted and then relapsed, and only 3% were well at the end of 1 year and still in care. Now that has not been. We've been telling it to the public for a long time, Matt, in America, but it doesn't go out through the media, and I don't understand why. The study should be retracted because there's research fraud involved.
Well, I
But
think
that's
you
a
do.
lot of study ever conducted. Go ahead,
I
Rich.
think I think maybe we do understand why, Robert, and I think we ought to talk about that next. And that's corruption. There's corruption in the system. I mean, obviously, with the number of flaws that you found in that study, one might ask, did they really expect to get away with such fraud? What were they thinking? But evidently they did, because they did. And as you say, the sale of SSRIs is going up, which means more money is being made. And we know the little slogan, follow the money. So we've got corruption in the profession of psychiatry, and we have it at many levels, don't we?
So it's so visible in this study. So if you look at the authors of that STAR-D study, many of them came from prestigious universities in the United States. Most of them did. Something like 11 or 13 of the authors had financial ties to drug companies that made SSRI antidepressants. So that means they were serving as their advisors, consultants, running their trials, etc. So they were known as thought leaders, right? Thought leaders are people who are key opinion leaders that the drug companies rely on to build a market for their drugs. So the very people testing antidepressants for the NIMH, in fact, were on the payrolls of the drug companies. Now, given that fact, from that point of view, they hardly want to say is these drugs don't work, which basically was the outcome you saw in the certainly in the year in study, but even the 35% remission rate isn't good after 4 tries. So they had to hide that. That's right. Now, I will say this. Their ties to pharmaceutical companies clearly were corrupting, but they also have guild interests. So the American Psychiatric Association, as a guild, as a trade organization, ever since the 1980s, what is their primary product? It's not psychotherapy. It's not psychological therapy. It's drug therapy. So if all of
Yes.
a sudden they come out in 2006 and said, guess what? Our popular antidepressants aren't working. They're actually increasing the risk you'll remain depressed. Well, that's something they couldn't do as a guild in a way to like say our product's not working, because what do they have left at this point? And if the antidepressants are seen as unhelpful, how about the rest of the psychiatric drugs? It would stir a real public sort of backlash against psychiatry and the use of these treatments. So they certainly hoped for much better results. And you can see that in their documents for planning the study. But when they got these terrible, terrible results, they just couldn't, because of the corruption you're talking about and the guild interest, they just couldn't bear to publish them. They couldn't bear to be honest with the public. And by the way, when this reanalysis came back last year, there was one journal I was quite amazed, the Psychiatric Times, which is it's a independent journal, but it is directed at psychiatrists, obviously, sort of an inside journal. I forget the editor's name. He said, if this is true, this is a real problem, because we relied on the STAR-D to guide our thinking now for 15 years. And if so, we've been misled. So that was sort of an admission of culpability here, that it was remarkable. But still, as the study been, we, by the way, Mad in America mounted a campaign asking the public to demand that this study be retracted from the medical literature. And the journal editor wouldn't even respond to us, even though they're duty bound to do so under ethical guidelines for medical journals.
I gather no one has asked you to go to Congress and give you a report to Congress?
No, No one has.
And
I mean, it's interesting. There is a veterans organization that has had a number of its members. They use antidepressants really heavily in the VA, Veterans Administration, and it's led to a
yes,
lot of suicides and adverse events. So there's a
yes,
veterans group that wants a congressional investigation. It's ongoing right now, this effort, and they want to bring me and others to and people who've done this research to Congress to speak now. But you remember, Congress gets most of them get money from lobbyists who represent the drug industry, both sides of the aisle, by
yes,
the way, Democrats
yeah.
and Republicans.
Now, don't I recall that Hyman himself had connections to the pharmaceutical industry? You don't remember that? I seem to. Is his first name?
I think I do remember that he was serving as a consultant, but
And
it's been a while.
I seem to remember also. In fact, I'm sure of it, that certain high-level psychiatrists from Harvard who were involved with the making of the DSM were directly connected to pharmaceutical companies, and they were increasing the number of diagnoses in order to sell medications that went with those new diagnoses. And I put that on the air many years ago.
Well, that's true. That's absolutely true. So if you look at who wrote the DSM-3, DSM-4, and DSM-5, particularly DSM-4, the majority of people broadening the diagnostic guidelines had ties to pharmaceutical companies. The majority, in some
Right.
cases, it was like 90%, and serving as thought leaders. So what do the drug companies want? They want expanded diagnostics, so that expands the market for the drug. And the very people that were on, say, the DSM-4 committees and the DSM-5 committees, on the work groups and the overall task force, yes, they were taking money from drug companies. And of course, the drug companies don't have to even say what they want done, but everybody knows what they want done. They want to make it easier to prescribe these drugs. And also, going to say one thing though. Yes, there's that pharmaceutical influence, but there's a guild influence too.
I
So
understand that. I understand that.
psychiatry as a guild wants as many people as possible under its domain of influence. So there's those two things go together.
So I presented a paper at the Psychedelic Science Conference in Denver, Colorado. What was it, in June of 23? And standing outside the conference center, I saw a group of policemen. There were about 5 of them standing there and talking. And on the grass in front of the conference center, there were people on blankets and playing guitars and looking very colorful. And of course, there was a big banner, Psychedelic Science. So I went over to the policeman and introduced myself to the officers. It wasn't policemen, it was policemen and women. And I introduced myself, and I asked them about if I could ask some questions, and they said, of course. And I told them about my program, Mind, Body, Health, and Politics. And I asked them how they felt about this psychedelic science conference. And the person in charge of the 5 of them, a female police officer, looked at me and she said, here's what it comes down to. Every single one of us on the force has had a family member fucked up by the big pharmacy medications. So if these people have something new to offer, you bet your ass we're going to at least listen to them. I thought that was a very telling conversation because it was with police officers and what they were saying. And really what we're saying, Robert, is that the whole United States has been taken in by this scam. I can't tell you how many of my patients contacted me after the interview 14 years ago with you and said, what the hell am I supposed to do now? I'm on these damn drugs, and I believe this guy Whitaker. He sounded like an honest man, and I'm on these things, and they're going to make me worse. What do I do? It was heartbreaking.
Yeah, listen, Richard, I get emails from people all the time, basically say, these drugs have made me worse. Now I'm a mess. I'm sort of stuck on them whenever I try to come off because of the withdrawal effects. It's such a It is heartbreaking, and the harm done is just like astounding. It just, and then when you start talking about people having this done to their lives at earlier ages, sent down this path of becoming mental patients, it is heartbreaking. It's devastating. And the other thing is, we really don't know the extent of the injury that may come from, say, long-term use of antidepressants or we do know
Ye-
with antipsychotics, but we're getting more
Yes,
and more information about sort of a nervous system injury that results from long-term use of antidepressants.
yes. That is very sad. Robert, we're going to take a short pause now.
Okay.
And what's going to happen in the pause is I'm going to ask you to be thinking about what if, what if we ended the interview right now and then pops into your mind one or more things that you wish you would have said. So after the pause, I'm going to ask you for the I wish I would have said stuff. And
Okay.
while you're doing that, I'm going to speak a little bit about the program, or you might call a commercial. Okay?
Okay. Sounds good. Sounds good.
Okay. So I want to thank you all for listening to this extremely important broadcast of Mind, Body, Health, and Politics. It's one of the most important, if not the most important, interviews in my 20-year career. I mean, what you're hearing is about corruption in the pharmaceutical industry that is having a negative effect on the lives of tens of millions, if not more, Americans and untold numbers around the globe. I'd like you to tell people about this broadcast. Let them listen and hear what Robert Whitaker has to say. Let them buy his book, Anatomy of an Epidemic. Let everybody go to his website, Mad in America, and look at what he's sharing with the American public. Please do that. I remind you that we broadcast Mind, Body, Health, and Politics every week. There's a new program. It airs at 9 o'clock Tuesday morning. But of course, it's all on the archive. And keeping with my 20-year tradition, all the archives are open source, free. There's no charge. Check them out, Mind, Body, Health, and Politics. And thanks a lot for participating. Now back to Robert.
That's a great thing. What I wish I had said. Well, first of all, just one thing I would say. This is not medical advice for the individual. We're just talking about what the research does show and sort of the harm to society as a whole. So this is not medical advice. And obviously, every individual has to make their own decision. But really, I think that for us all here today, including the audience, how can we best understand this story? And we can understand it in this way, is that American Psychiatry, beginning really in 1980 when it published the third edition of its Diagnostic and Statistical Manual, it wanted to tell a new story. It wanted to tell about diseases of the brain, and it wanted basically to make drugs a first-line therapy. And that's the story they told. They told us a story of great medical progress, of drugs that fix chemical imbalances, of a second-generation drugs that were like making people feel better than well. Unfortunately, that wasn't a scientific story. That was a story of marketing. So we as a society and individuals organized our thinking around what I like to call a false narrative of science, because it was pitched to us as science, but it was really a marketing story, which leaves us today with a social responsibility, because they expanded this story to children, changed how we think about our children, how we raise our children. So what I'd like to leave the audience today with a question is, what do we do? How do we now organize our thinking and our care around an honest narrative of science, particularly since the media has been resistant to bringing forth the very science findings that I've been talking about over the past hour? Now, you can find all this on Mad in America. You can see for yourself this. We have drug resource sections, et cetera. But it's really a social responsibility for us now. How do we raise our children so they don't end up medicated and diagnosed? Because that's a story of great harm. And how do we develop a new narrative, A new narrative that tells about how human beings can struggle, can suffer, but that can not happen to almost anybody. And so often, such struggling is in response to environments, and it's episodic. So, how do we recover a new narrative that gives us hope and gives us an understanding of how we can better help each other when these difficult times arrive? But that's what we need. Is we need a societal discussion. It's not going to come from within psychiatry, in which we reconceive this whole story. And final thing is, the World Health Organization and the United Nations for Special Rapporteur for Health, Danish Burst, have issued extensive documents saying this old way has failed. We need a new narrative. And now my pitching to all your listeners is put this on your mind and help us think of a new narrative, one that's optimistic, hopeful, and congruent with science.
Thank you, Robert Whitaker. Thank you so much for being with us today.
It's my pleasure.
And thank you, gentle listeners, for being with us today on Mind, Body, Health, and Politics. I remind you that Robert's book is Anatomy of an Epidemic. His website is Mad in America. I want you to check them both out. Until next time, this is Dr. Richard Lewis Miller reminding you that good health is worth fighting for, and it's essential for life, liberty, and the pursuit of happiness.